do I proceed with my next talk? I have another talk on keratoprosthesis simplified. All right, so I'll try to simplify the keratoprosthesis. Now, basically, there are varieties of keratoprosthesis which are available, and I'll lay my stress on Boston keratoprosthesis type 1, and I have no financial interest, of course. Boston keratoprosthesis, primarily we use the type 1 for the wet conditions, that is the wet ocular surface, and there are other conditions wherein when the ocular surface is dry, we use the other type of keratoprosthesis. The Boston keratoprosthesis type 1 involves primarily the front plate, which is made up of PMMA, and the back plate with multiple holes so that the seepage of aqueous is possible, and it comes with a titanium locking ring. And now even the back plate is coming in, it is being made in titanium. And traditional indications have been for multiple failed keratoplasties, and ideally either minimum of 2 keratoplasties which have failed, and visual acuity of 2200 or less in the operative eye, and there should be, most importantly, a potential for improved visual acuity. Patient selection is extremely paramount in Boston keratoprosthesis. As I told you, the tear function should be quite adequate, so these are the kind of eyes which we take, and these are the kind of eyes which we do not take up for type 1 keratoprosthesis. Again, there should be adequate eyelid functions, so these kind of cases are strict no for type 1 keratoprosthesis. And typically it's best to avoid patients with autoimmune diseases like pemphigoid or Stevens-Johnson for type 1 keratoprosthesis or after severe chemical injury. Now, this is one of the case histories which we've done the keratoprosthesis, 64-year-old man who had twice failed keratoplasties, total limbal stem cell deficiencies, and on top of it he's had multiple retinal surgeries for retinal detachment, and his other eye has been phthisis bulbi. Vision is only PL and with accurate PR in one eye, the other being PL negative. He's the one who pleaded that at least he should be able to see the food on his plate. That was his pre-op condition. The only seeing eye which had PL vision was like this, and post-Cape Road, this is the vision, and he was pretty happy that he was able to see at least the food on his plate. And this is the other case which we've done, 58-year-old gentleman, cataract surgery 9 years ago. He has an aphakic bullous keratopathy, underwent penetrating keratoplasty 2 years ago, which failed, underwent a DSEC 2 months ago, that also failed, and the other eye has a CRAO with advanced glaucomatous disc damage. And again, his vision was only PL. We combined the Boston Cape-Pro with Ahmed valve procedure simply because he had an advanced glaucoma in the other eye. And this is the vision which he had. Day 1 was 3 meters, and at the end of 3 weeks, he attained 6 by 18 vision, and he continues still to maintain this vision. And there's another case who had thrice failed keratoplasty, the other eye being phthisis bulbi, and he was pleading for some vision, and this was his vision, only PL and PR. And that was his post-operative condition. Again, we clubbed with an Ahmed glaucoma valve, and he was pretty happy to see now this gentleman who used to come with his daughter-in-law all the time, who used to accompany him. Now he comes all alone from a distant place for follow-ups. This is another case of a Stevens-Johnson for which we've done, a very young girl who comes from a distant place, and this was her condition of both the eyes. And this is the condition of the eye after Boston keratoprosthesis. She was the one who never went for school for the last 5 years, and she was mighty happy to get back to school after Boston keratoprosthesis. She's the one whom we've done keratoprosthesis in both the eyes, and she's doing pretty well in one eye. And there's another lady of advanced ocular cicatricial pemphigoid. Look at the keratinization which keeps coming recurrently, and the other eye she's totally lost due to ARMD. And this is the post-op picture of the same lady after keratoprosthesis, and she's able to do her routine normal work. And this is another kid, 10-year-old kid who had grade 4 chemical injury with multiple surgeries involving cataract, tectonic keratoplasty, full thickness keratoplasty, limbal stem cell transplants, and this was his condition. And then we decided we'll do the Boston keratoprosthesis for him. This is his condition pre-op to keratoprosthesis. This is following mucous membrane graft, and we never even had an inkling as to where the limbus is for us to do the Boston keratoprosthesis. We nevertheless proceeded with it, and this is how we ended up giving him a reasonably good vision of about finger counting 2 meters. I'll just show you the surgical technique of the Boston keratoprosthesis. Now it is pretty similar to the penetrating keratoplasty, except that the assembly of the Boston keratoprosthesis is important. Rest of the procedures are pretty similar to penetrating keratoplasty. We just mark the peripheral 8 mm trephination. This is the host cornea which is being trephined, full thickness. Carefully we'll have to remove. This is the person whom I talked about who had an amide valve already in his eye. So carefully we'll have to dissect his damaged cornea. Once we remove it in toto, these are the conditions where the anterior segment is very much distorted. We'll have to reform the anterior chamber. Look at the length of the amide valve, it's too elongated. We just trim the amide valve tube. Now this is the donor cornea. We just have to mark the center first and trephine a central 3 mm hole, full thickness. Once that is done, we place the anterior, front plate of the keratoprosthesis upside down with the stem pointing towards us. Just place it there, then slide the donor cornea button over it. Just push it back. Once the donor cornea button is in place, we put some visco over it and then slide the back plate, which has multiple holes to facilitate the aqueous. Then we put the titanium locking ring in place and then just slide it back, and this is the complex of Boston keratoprosthesis which is ready for suturing. Suturing is similar to the full thickness keratoplasty, but at times it's pretty difficult because of the distorted anterior segment. This is how it appears at the end of surgery. Right, management is pretty similar to post-op keratoplasties, but then these are the patients who have to be maintained lifelong on antibacterials once a day, and also we prefer to use a contour K lens for the rest of the life. Complications are not alien to this procedure. Most common complications are retroprosthetic membrane formation, which could be very thick at times, necessitating a membranectomy. If it is very light, we can manage with only YAG laser capsulotomy. The corneal stromal necrosis is pretty common, especially in those eyes wherein the tear surface is pretty poor. We can also have infectious keratitis, which needs to be adequately managed. Endophthalmitis is not rare again, and especially in those cases wherein it's a single chamber globe, best managed in consultation with a vitreoretina colleague. And glaucoma. And glaucoma is one which needs to be very carefully assessed for progression, simply because it's very difficult to assess the tension in the keratoprosthesis. Most common mode of measurement is finger tension. We can also use the transscleral tonometer. Most important again is the structural evaluation. Can you assess the optic nerve? We can use the OCT, HRT, GDX, and we can document. This is a girl whom I was talking who had bilateral keratoprosthesis. One fine day, after a full 6 months of not following up, she just came back one day, and this is how her K-Pro was. Remember, these are Stevens-Johnson cases, extremely inflammatory conditions, and this is how the K-Pro was, and it was partially in and partially out. We proceeded and did a hemitectonic keratoplasty, and we were able to manage and save the keratoprosthesis, simply because if we take out the keratoprosthesis, it's pretty difficult again to get the keratoprosthesis and redo the procedure. It's a careful selection of cases is very paramount. Most important to have regular follow-up and compliance. Where there's futility of keratoprosthesis is extremely rewarding. Spectacular visual outcomes can be obtained after Boston keratoprosthesis. But what happens in such cases where the tear film is almost negligible or absent? These dry cases necessitate not the type 1 keratoprosthesis but other keratoprosthesis. What are the other types of keratoprosthesis which I am going to simplify? We can either have the here we have the Pintucci keratoprosthesis, which primarily has a Dacron mesh with the central PMMA stem. You can also have this alpha core or the modified osteodonto keratoprosthesis. This is the type 1 what I have now talked about all this while. But they also have this type 2 keratoprosthesis from Boston, which has a central anterior nub which protrudes through the eyelid, and this is how it would be visible at the end of surgery. But then the Boston type 2 fell out of favor simply because there was a lot of stromal the skin necrosis around, and which led to infection and endophthalmitis. Alpha-Gore again has not found very good taste with keratoprosthesis surgeons simply because of enhanced cases of extrusion. It primarily involves a central PMMA with a peripheral skirt, and it involves 2 steps of surgeries, and it's not in a very good favor with the keratoprosthesis surgeons. Pintucci is one which we can think about. Very simple to use. It has to be it's biointegrated with the Dacron mesh so that it can be integrated within the corneal stroma. It involves 2 stages. In stage 1, we have to implant the K-Pro into the lower eyelid for 46 days, and at the same time we have to put the ocular mucosa onto the cornea. Second stage, we can put the cornea. We can put the K-Pro. Finally, we have the osteodonto keratoprosthesis. Professor Strampelli in Italy was the one who pioneered it, and Falsinelli has been following it up for the last 40 years. It involves 2 stages. Stage 1 is removal of the canine tooth, and then putting the cylinder into it. Stage 2 involves the removal of it from the lower eyelid, cleaning it, and then implanting it onto the ocular surface. It has its own list of complications. Fractures of the tooth can happen, bleeding into the vitreous chambers, and infection as with any other surgeries. Retroimplant membranes are rare in this procedure, but they can still occur. Thank you so much for your kind attention.